I'm Alberto Lorenzatti, and it's a great pleasure to be here. This is a summary video corresponding to the full version that you have on demand. We will address new strategies to mitigate the residual vascular risk in diabetes. These are my potential conflict of interest. We will address the prevalence of cardiometabolic risk factors in Latin America, diabetic dyslipidemia as a perfect storm, remnant particles sleeping with the enemy, managing dyslipidemia to reduce cardiovascular risk, targeting triglycerides to reduce residual risk, emerging therapies, and finally, concluding remarks. The last big epidemiological study that was Interheart study in its Latin American version has shown that obesity has become a major health problem in Latin America, especially abdominal obesity, with a population attributable risk of near 50%. In the second term, dyslipidemia, assessed by the relationship between ApoB and ApoA1, was a second population attributable risk in the region, counting on about 40%. Recently, a group of Latin American experts, we published a Latin American consensus on the management of residual cardiometabolic risk. This is the central illustration of this publication that is showing that there are 5 crucial factors that we have to manage in order to reduce the risk in cardiometabolic patients: inflammation, hypertension, the glucose metabolism, prothrombotic risk factors, and atherogenic dyslipidemia. We will focus in this kind of particular dyslipidemia. What about diabetic dyslipidemia, the perfect storm? There are some changes, qualitative, quantitative, and metabolic kinetic changes. For example, chylomicrons show a higher production and lower catabolism, VLDL, more production and less catabolism, the presence of small and dense particles of LDL are the rule, with LDL particles enriched with triglycerides, and finally, higher catabolism of HDL that also are enriched with triglycerides. What about the remnant particles? This cartoon is showing that chylomicrons represents the exogenous weight for triglycerides, and VLDL particle the endogenous one, and both kinds of lipoproteins undergoes the lipolysis via lipoprotein lipase, and the remnant particles are particularly enriched with cholesterol and small enough in order to penetrate in the subendothelial space and promoting atherosclerosis. In the clinical practice, we can calculate the cholesterol remnant, subtracting from the total cholesterol HDL, which is non-HDL, and finally subtracting LDL, and the amount should be, it's not well standardized, but should be less than 30 or 25 milligrams per deciliter. This elegant study is showing, this study is part of the PREDIMER study, near 7,000 patients. They have the population were diabetic, and followed by 5 years. The Kaplan-Meier curve in red is showing patients with more than 30 milligrams per deciliter of cholesterol remnant, and the blue one is showing the patient with more than 25 milligrams per deciliter, but with LDL less than 100. In both cases, there were an increase in the cumulative incidence of cardiovascular events. What about the managing of dyslipidemia? We propose in the Latin American consensus, I will focus just in very high-risk patients. Less than 55 milligrams per deciliter is the goal. If the patient doesn't achieve the proposal is to add PCSK9 inhibitor or ezetimibe if the patient is on target, but triglyceride is more than 200 milligrams per deciliter, or non-HDL is elevated. The recommendation is to add omega-3, EPA, or fibrates. In the case of statin, please use the proper dose. I mean, high-intensity statin. You can see in this elegant work from the TNT study, patients with more than 24 milligrams per deciliter of cholesterol remnants showed a clear benefit, but in favor of patients taken atorvastatin 80 milligrams per deciliter in comparison with atorvastatin 10 milligrams per deciliter. What about PCSK9 inhibition? We published data from 2 studies gathering 1,400 patients, and we divided in patients with atherogenic dyslipidemia and without atherogenic dyslipidemia, or were patients with diabetes treated with atorvastatin, and on top evolocumab versus placebo. You can see the decrease of LDL, the reduction in LDL was similar in all groups of about 70%, and a vast majority of the patients, I mean between 70 and 80%, achieve the target recommended for the European guidelines, less than 55 milligrams per deciliter, plus a 50% or more of LDL reduction regarding baseline levels. In a very interesting way, also there were VLDL reduction and remnant cholesterol reductions in patients treated with evolocumab, but in the subgroup of high triglycerides and normal HDL, or high triglycerides and low HDL, I mean atherogenic dyslipidemia. This effect was just minimum in the patient with no atherogenic dyslipidemia. What about targeting TG to reducing risk? I do have to say that statin is the first-line therapy. We have comment about fibrates, omega-3, but taking account that there are, for example, volanesorsen, that is an anti-ApoC3 oligonucleotide antisense that can decrease triglycerides in a very strong way. Finally, there are some emerging therapies. I have mentioned volanesorsen that is capable to block the ApoC3 production, and consequently the reduction of TG is very important, and also molecules that target angiopoietin-like protein 3, and the result is the reduction of VLDL and LDL. All are new drugs in development, and I'm sure they will be very useful in the near future. My closing remarks: atherogenic dyslipidemia is very prevalent in Latin America. The changes are profound: qualitative, quantitative, and kinetic metabolic alterations. The lifestyle changes are fundamental. LDL cholesterol control is the priority, with the statins in the proper dose. Ezetimibe or PCSK9 inhibitors can be added when the LDL goals are not reached. Fibrates or omega-3 should be considered when triglycerides are persistently elevated, and new drugs with novel therapeutic targets are under development. Many thanks. Obrigado.